Welcome to the Bridge Talk Show. My name's Vivienne Parry, and in the first episode, which I urge you to watch, we talked about the pathophysiology of type 1 diabetes and why early detection was now possible. What we're going to do in this episode is talk about why it matters so much. So let me introduce you to our guests. Firstly, Kimber Simmons. Now, Kimber is a pediatric endocrinologist. She comes to us all the way from Colorado, where she works at the Barbara Davis Center for Diabetes. Welcome to you. And we also have Jurgen Vercauteren. Jurgen is doubly qualified to be here because he not only lives with type 1 diabetes himself, but he works as a researcher in diabetes alongside Chantal Mathieu at the University of Leuven. Welcome to you both. And let me turn to you first of all, Jurgen. When were you diagnosed?
I was diagnosed 10 years ago, and indeed, it's good that you mentioned type 1 diabetes as a different disease as type 2 diabetes. I think it's important to stress that, because a lot of people with T1D were first diagnosed as having T2D. So that's good that we stress that we're talking about type 1 diabetes here. And also the symptoms can appear at any age. For me, I was quite late diagnosed at the age of 39, and I still think that the disease is a tough disease. I'm struggling with it. It's a 24/7 burden. I'm going high, I'm going low. So, and there is always the fear of having complications in the long run. So it's a tough disease. You cannot underestimate it. If you think globally, almost 9 million people have T1D. And more than 2 million of them are adolescents or children with type 1 diabetes. Another number, which is really striking, is that last year, 30,000 children or adolescents died at the onset of type 1 diabetes, mostly because of the dangerous complications as diabetic ketoacidosis or DKA.
So how did you first know that you had type 1? What were your symptoms?
I had the classical symptoms of being extreme thirsty, I lost weight, felt very tired, but of course you don't see type 1 diabetes as the cause. To be honest, I
thought you were 39 and...
Indeed.
You were losing your youth. That's
Indeed.
What it was going to be like.
In fact, it's nice to mention the story. I was standing in the bathroom with my wife, and she was pregnant with our third child. So she was having a nice belly, and she looked at me and she said, "You're looking very skinny." And my wife is very intelligent, and I said to her, "Okay, what should I do about it?" And she, of course, advised me to go to my GP. And there I was. It was at the 31st of December, 10 years ago. And as a New Year's Eve present, I got the diagnosis of T1D.
But Kimber, that's often, that's the classical symptoms, but often that's not how people present, is it?
No, I think it depends on where you're at geographically, because it can really vary in what that looks like. But a lot of kids that come in are really, really sick when they come in with something called diabetic ketoacidosis or DKA, which is a much more dramatic entry into type 1 diabetes. And I mean, your entry was quite dramatic too. But when you land in the hospital and you become very quickly ingrained in the medical system, I think it's a different scenario for a lot of families.
Are these DKAs preceded by the classic symptoms of thirst and frequent urination? And
yes, so DKA most of the time is preceded by all those classic symptoms. And I think what's really challenging is you talk to a family, and when they look back, they can recognize all those things that happened, and they carry so much guilt because of that. But those classic symptoms can overlap with so many other common pediatric or adult illnesses or just symptoms, turning 39 or going through a growth spurt.
Well, you can just think they're hot, they're thirsty, they're just drinking a bit more.
That's right. It's summer and we're playing sports. And so my kid was, of course, thirsty. And so those symptoms can go unrecognized. Some parents that take their kids to the doctors actually are turned away from the doctor because they're given reassurance or told it's something else, and they return multiple times before they end up being diagnosed with type 1 diabetes and ending up in a crisis.
So what's going on when DKA occurs physiologically?
So DKA is a result of not having enough insulin, so insulin deficiency. People often think of it being the high blood sugars that cause the issues, and really that's just a side effect of not having enough insulin. So insulin is a hormone that lets the glucose move into your cells for fuel. And when you don't have insulin around, then it sets off a whole cascade of things. One of the things that it does is that it causes your body to release counter-regulatory hormones. So your body is sensing starvation, and so you start to release adrenaline and cortisol and growth hormone. And all of those things cause your liver to actually make more glucose and to cause you to break down glycogen. And so while your body is starving, we have a great backup way of getting that fuel, which is breaking down fat and making free fatty acids, which then go to the liver and turn into ketones. And ketones are a great fuel for your brain and your heart. They don't fuel your muscles very well, so often people are very tired. But what also happens is they're very acidic. And so people's blood becomes acidic and they try to breathe off the acid. We call that Kussmaul breathing. And at that point, people are really starting to get sick because not only is their blood acidic, but they've become so dehydrated from having all of that extra glucose that they're trying to pee out along with all the water and electrolytes they're losing that it can be life-threatening.
And that's the real thing, life-threatening. I mean, when somebody presents with DKA, this is a proper emergency.
Yes, it is.
Yeah, I can also speak to that because, of course, I didn't run into DKA myself when I was diagnosed, but of course I meet a lot of people with T1D, and they all have a terrible story to tell when they were diagnosed first. Actually, in Identify, I work in Identify, this European consortium for screening early stage T1D. We have a patient advisory committee consisting of 8 people living with the disease. And I remember 2 of them, or actually one of them said that she had to be flown in by helicopter to the emergency room, and she spent 7 days in a coma. But of course, that's more Kimber to elaborate on, I think.
Yeah, I think what is hard, every time that somebody comes in, if you see them as a medical provider when they first arrive, it's shocking every time. It's not something we get used to because these people are so incredibly ill. And, they're at a point where they're so dehydrated that they have a hard time having good blood flow, but yet they have to have 2 IVs put in just for treatment. And so it is a real serious thing. And every time that you walk into a room, you see that. You see how sick the kid is. You see the family that went from having a kid that was completely fine and going to school who just crashes, and now they don't really know what's happening with their kid. And, if they're going to end up they know that they have diabetes, which is scary in itself, but also are they going to make it be healthy through this acute event that they're having?
And they don't all survive.
They don't all survive, which is very, very sad. We should do better.
So it's a very scary situation, even for you as a physician who sees many episodes of DKA. When a child, or even an adult, but a child arrives with DKA, your heart must sink.
It is so scary. And I think over time, DKA has even become more severe. So people coming in even later and more acidotic, and you go in and you see somebody and you don't know if they're really sick, how they're going to do. You always hope the best, and lots of people that are really sick end up doing okay, but there's always the chance that that person might not do okay. And so it's a really critical time period where it's very scary.
And how many people are diagnosed with type 1 after a DKA episode?
The amount of people diagnosed with DKA varies worldwide. So in less resourced countries, we don't even have data to say how often it is, and it's probably much higher with much higher death rates. From the big registries, which are mostly in Europe and the United States, we know that ranges probably somewhere between 20 to 50% of people or kids that come in DKA when they're diagnosed.
Yeah. In India, in the natural history study, they've seen 44% of adolescents coming in with DKA, which is a very high number, and we can prevent that number. I mean, we can do something about this DKA, and that's all about early detection.
So what I'm taking away from this from you both is that this is DKA is an acute medical emergency, high death rate, and probably about 30% of children who are coming in, this is their first knowledge that they have diabetes. So late diagnosis has a huge impact, both for the family but also for the healthcare professional. And we're going to go on to talk in a little while about what the impact is post that DKA episode. Welcome back. Now, Kimber, when you have these kids come into hospital in acute crisis, presumably most of them go on to the ICU.
That's right. So probably over half of the kids and adolescents that we see end up in the intensive care unit or the ICU when they're first diagnosed. And that really depends on how acidotic they are and how young they are. We try to have everyone who has a lot of acidosis and a lot of who's a younger age end up in the ICU because that's where they can be cared for the best. And sometimes we're balancing that with a really full hospital where there aren't beds open because those kids really need to be in the intensive care unit in order to have the level of care they deserve, which are glucose checks every hour and a really intense recovery for diabetes. And that recovery can take days when kids first come in diagnosed. So often kids are really sick, not really that with it when they first come in. And then as time goes on, they may start to feel a little bit better, but they still have to sit in a room with all of the medical equipment, IVs in both arms, and they're not allowed to eat or drink anything until the acidosis resolves. So it's a really hard time for the kids and family when they're in the ICU.
So scary for the kids, terrible for the parents, scary for you as medical professionals, but scary for another reason for those parents, particularly, of course, in the US, is the cost of ICU is enormous. And I guess lots of people don't have that provision in their healthcare plans.
Yeah, so in the United States, we have a mix of private insurance and government insurance. And what's really difficult are people that have private insurance plans. A lot of them have what are called high deductible plans because most of the time these people have otherwise been healthy and haven't had medical issues. And so they don't think that they need to have a big health insurance plan coverage. And then they come into the hospital and into the ICU and it's tens of thousands of dollars. And so families not only are in emotional crisis and their kids in physical crisis, but they're also entering a financial crisis at the same time.
And there's another crisis going on, which is that these kids who first present with DKA, their future prognosis is worse than kids who don't present in that way.
I find that one of the most challenging things because when a family comes in with a kid who's in DKA and then afterwards when they've recovered and you're doing education, it's really hard. The families who don't come in DKA, you can tell them it's really good that you didn't come in DKA because your kid is set up the best that they can be to live with type 1 diabetes. But when you have a family who is just in DKA, I tend to not say a lot about that because there's nothing you can do at that point. But you know that those kids potentially have a higher hemoglobin A1C concentration in the future, potentially an increased risk for complications in the future, potentially some neurocognitive minor deficits, but changes in the brain that they otherwise wouldn't have had. So it's really sad that kids are entering diabetes with all of those things because they were in DKA first.
Yeah, and can I remind you that also these children are very young, so we see that the disease is becoming more aggressive at a younger age. So these are really young children of 1, 2, 3 years old, and it must be very traumatic for them and also for the parents to experience this. And so I think there will also be a psychological burden to take that with them. It's very difficult to go through that phase. And I just read a survey by the Australian Breakthrough T1D organization, and it was there mentioned that 85% of the people responding to the survey, people with T1D, were saying that they wish they had known that there was something to do with that they could do early detection to prevent the DKA. So even people with T1D are saying we should get rid of this DKA. Let's do it. Let's do something about it.
And can I ask a question which I absolutely don't know the answer to is, if you've had DKA once, is that it? Or do you then tend to have DKA again?
That's a really good question. The answer to that question is that if you are in DKA at diagnosis, you're actually more likely to have DKA again. And there's a lot of reasons that may occur. One is just because when you enter in such an acute crisis, a lot of your residual cells that make insulin are really damaged, and so those people probably have less protection long term than people who come into diabetes more gradually.
So it's a kind of crash into diabetes.
Right.
Wow. And so again, I'm coming back to that word scary. I mean, it is scary for everyone. And one of the things that's disturbing as well is that I think you see DKA more often in people with lower socioeconomic conditions. And that's very tough.
It is very tough. So our most vulnerable patients, our youngest patients, our patients who are of lower socioeconomic status are the ones who are more at risk for presenting with type 1 diabetes in this serious situation that is very scary. And I think one of the things also is when you're hit initially with that really scary situation, it sticks with families. So families are very, very scared of that happening again long term. And coming in right after hospitalization, they think if the kid has another high blood sugar, they're going to end back in the ICU. And so it takes a lot of time to really come to grips with what diabetes management looks like, when you have to be concerned about high blood sugars, and there's a big emotional and psychological toll to all of that.
Now, we've been talking together about the huge impact of DKA. Can we prevent DKA with early diagnosis?
So this is one of the areas where the data is actually really, really clear. And it shows us that if you screen for type 1 diabetes early by measuring islet autoantibodies, that you can dramatically reduce the risk of DKA down in most studies that have screened to less than 5%. And what I'd say is there's a benefit beyond screening and following people and getting to that 5%. We know that even if you screen and people don't follow up, that there's still about a 50% reduction in DKA when they come in.
That's astonishing. And what do you think it would mean for people living with diabetes to have that early warning?
Well, very important, of course. I already mentioned that people with T1D might think that they would see the symptoms on themselves or on their children or relatives very easily, but I don't think we should take that risk. Why would you take the risk if you can just have your children screened and then be probably reassured, or if not reassured, you can deal with it, because you can start preparing for the day will come. Then you will have to start using insulin on your children. You can take part in clinical trials. You can have psychological support. So there are many advantages to it, I think. Even for people with T1D already, I think we still have a lot of things to do to convince also those people to have their children screened.
Now, you've got 3 children. Mm-hmm. Have you had them screened?
Good question. I did, of course, but I couldn't work for Chantal Mathieu if I wouldn't have my own children screened, of course. But having T1D myself for 10 years now, and my daughter is also 10, so actually I was able to do the screening on my daughter, but I was not aware of the fact that you could also do autoantibody screening. I was aware of the fact that you could do genetic screening, but it's important to stress that's different. So we can look for the genes that can predict the onset of T1D in a child, in a newborn already, but that gives you only like a risk determination. It's not, you're not completely sure. And for me and for my wife, we didn't do it because for us it was like a sword of Damocles hanging above our head. I do believe that genetic screening is important, maybe for enriching the population that we then later on can screen for autoantibodies. But for me, it's an and story. So genetic screening and looking for the autoantibodies. So of course I did. I screened my 3 children and we were quite reassured. The 3 of them didn't show any autoantibodies. And by next year, I want to rescreen them. And then if again 3 of them would be negative, I will be quite reassured, because I think we've got a quite powerful tool here. And I don't have to live with that worry anymore. Because as a parent living with T1D myself, you're always worried. You're always worried, and you actually are a bit feeling guilty that you might pass on the disease to your children. And with early detection, with screening for autoantibodies, we can take away those feelings.
And you should never underestimate, I don't think, the psychological burden of type 1 diabetes.
Indeed. It's there 24/7. And it's always a burden. And I'm a grown-up, I can deal with it, I can manage, but it must be very difficult for parents having children with T1D, very young children with T1D. So that's very worrying, and we've got we've got ways to at least detect the disease in an early stage. And if you find 2 or more autoantibodies, we can define the disease as having early stage T1D, and then you can deal with it.
And I think even something you said earlier about most people missing their symptoms, in little kids, when they're diagnosed, their symptoms may only be there for a couple of days before they end up in the ICU.
It's a tiny window, isn't it?
Tiny window, and that's why screening, especially in young kids, can just really be so impactful.
Gosh. Jurgen, you said how this great psychological burden. Will you ever feel confident about your children? Or will you want them to carry on with testing?
Well, maybe it's not needed to have them retested over and over and over again. I think my son will be turning 18 next year, and if I have him tested by then for the second time, and he will be negative, I'm sure, I'm hopeful, then I wouldn't do another testing anymore, because the chance that these autoantibodies will show up later in life is quite small. Of course, there is no test which is 100% safe, but these screening methods are quite very good in sensitivity, specificity, and a very high positive predictive value. So, we can trust those tests, and they're becoming even more trustworthy.
Now, you're an educated, highly sensitized to type 1 person. And working with Chantal, of course, you have to be. But actually, we were talking earlier about how this has such an impact, DKA, on people with low socioeconomic status. So how can we ensure that autoantibody testing isn't something simply for those who are, more educated?
Yeah, I think it's very important what you say here, because I hope that we're not doing something only for those children who are privileged to have parents who are highly educated and are knowing about these new techniques. And we see in our screening programs that most of the children screened are the ones from highly educated parents, and that's something we have to do something about it. Now, I already mentioned that I'm working as a project manager in Identify, in European Consortium for Screening, and in there we are testing different ways of screening. So we do it in hospitals, but we also go to schools, we go to the GP offices, we go to vaccination centra, we even go to playgrounds and sport facilities, because we want to have the threshold for being screened as low as possible. And we also test with dried blood spot cards that we mail to the persons, to the families, and they can just mail it back for free, so that we lower the threshold. And that's very important to have an inclusive way of screening.
So, Kimber, we've talked there about the importance of the soft landing, as it were, that early diagnosis provides. But what else can we do when you get an early diagnosis?
So, back to just to touch on the soft landing piece, I think people don't understand exactly what that means sometimes. And I think just to help you understand a little bit, if a kid comes in and they're in DKA and they didn't have a soft landing, they have high glucose levels, the parents are very scared about those high glucose levels, you're immediately starting insulin. We're trying to give the right doses to bring the blood sugars down, but not too quickly, because we don't want them to have low glucoses or have them feel really bad in that acute period. And so that first month is actually really, really hard as a transition period. But if you have somebody who's screened and is caught early, that is a much more smooth transition, where those patients are usually started on much softer insulin doses, don't experience low glucoses right away, aren't feeling sick, and that goes a lot better for families. So I think that's a really important thing. But you talk to people and what are the motivators around screening? A lot of families may not say that they want to learn more, or may not really understand what it's like to have a soft landing when they're diagnosed. But if you talk with them and you say, hey, there may be things that we can do earlier. So there are lots of clinical trials, more and more, that you might be able to participate in that are aiming to eventually prevent or slow down the progression of diabetes. That's a big motivator for some families and for some clinicians. And so there are many reasons, and for one person, one individual, it may be a different reason that makes them want to find out and to screen their kid or themselves for type 1 diabetes.
I mean, we talked in episode 1 about the genetic background and how it's more common in people with families with type 1, but it's not exclusive.
No.
So many people will have no history. So whereas some people who have family connections may be very keen for screening, we have to get a much wider message out to people who think that they probably have no risk at all.
No, don't forget that 85% of the new cases of clinical T1D are happening in families with no family history of T1D. So if we really want to get out there and detect most of the cases, we have to go to general population screening and not only stick to the relatives of people with T1D. That's very important.
Yeah, and I think when people who have a family member with type 1 diabetes, the conversation actually is a little bit harder sometimes because as you mentioned earlier, they think that they'll catch diabetes, and some people don't actually see the value in screening until there's something that they may be able to do, like a trial or a treatment. But when you're talking with the general population, it's usually not about that. It's a little bit of an easier ask, but it's harder to educate because most of the general population knows a lot about type 2 diabetes. So in order to screen them and for them to understand what they're actually being tested for is a challenge.
Yeah, and you touch upon a very good thing. Education is key here, and communication is also key, because once you diagnose a child in an early stage of T1D, there can be months, but can also be years before symptoms will arise and before the child will really have to start injecting insulin. And so, I mean, we will have to follow up those children, and communication is very important to not lose them, because they will have to come in again for regular checkups, and it's very important to communicate that to the parents and to the children as well, that it's very important to do something with it.
Opportunistic testing is presumably important in the absence yet of, full-blown screening programs. How do you deal with that?
Well, I think that there are always opportunities to test kids. In the United States, we've tried to work with pediatric practices to align it with visits where kids are already getting blood drawn. So things like getting a hemoglobin checked for anemia, or lead testing, or lipid panel. Those are times where there are guidelines in place to do blood testing, and so it becomes a little bit easier. But we also know that there are a lot of other autoimmune conditions that people have that require frequent blood tests. And so to add on islet autoantibodies at times where people are getting routine blood work, especially in those who have another autoimmune disease, makes a lot of sense.
And I've seen quite a lot of misclassification between type 2 and type 1. So are these autoantibodies useful in that sense too?
Yes, I think they're very helpful. So even in our pediatric population, we have made it standard where if anyone who has prediabetes and has a family history maybe of type 2 diabetes or obesity, we still check islet autoantibodies, because we find a certain percentage that have type 1 diabetes, because anybody can get type 1 diabetes, people of all shapes and body sizes and all races and ethnicities.
The elephant in the room is screening, or either whether it's opportunistic or whether in the future, population screening, expense and cost. Can it be cost effective?
Of course it is. I think you should also ask Kimber the situation in the States, which is completely different than maybe the situation, for example, in Belgium. In Belgium, I don't think early detection, I think we should call it early detection, is maybe not cost effective, because we have a universal healthcare program. But in other countries in Europe, it might be similar to the States. So Europe is not one size fits all. And in Identify, we're also studying the cost effectiveness of screening. And it will be country per country differently.
I think it really depends, and we still need a lot of data to see, even throughout the United States and different populations, how it's cost effective. We know that the majority of cost effectiveness depends on if you're reducing DKA, and so reducing DKA makes it more cost effective to be screened. And there isn't data yet, but as treatments are approved, that will be another factor that plays into whether a treatment is cost effective over time, or a screening is cost effective over time.
So what would your message be to all those people who are watching this? Healthcare professionals, working in diabetes, what would your message be about DKA and its impact and severity?
I think that we have an obligation as healthcare providers to encourage people to test for islet autoantibodies and be screened because the data is so clear, showing that it reduces the risk of DKA, and we know that patients do better if they don't end up in DKA when they're diagnosed. So it's our professional obligation to try to get rid of DKA and set people up for success with a chronic condition until we can do something to prevent or delay it.
Yeah. For me, early detection is a no-brainer. I would recommend it to everybody because don't forget that in more than 99% of the cases of children screened, you will be able to tell a positive story. You'll be able to say your child doesn't have any antibodies. It doesn't mean that it will never have them, but maybe you can have them rescreened after a few years and maybe if possible a third time, and it will only reassure you in the end. So I think it's a positive value as well. And it's completely different from screening for types of cancer because it's all risk determination. It's also important, of course, but that's a very personal decision, I would say. And I would prefer not calling what we are doing here screening, but really detecting the disease in an early stage.
Kimber Simmons, Jurgen Vercauteren, thank you so much for being with us today. So what we've learned is that DKA is a severe, life-threatening condition that requires immediate hospitalization and far too often ICU admission, resulting from severe insulin deficiency. It's a result of progression to stage 3 T1D that's not been recognized. And the impact of DKA is lifelong in terms of glycemic control and well-being. But the really good news is through early detection, it can be reduced and even prevented, and that's through screening of autoantibodies. See you again in our next episode.